Every system in the body is affected by aging. And it's going to be variable from person to person, but you are aging. Everybody is. We all are. So whether people want to admit it or not, they're aging. So there are changes to the integumentary system, to your skin and your mucosa as well. Some of them are related to genetic factors. So I remember when my paternal grandmother was in her 80s, she had great skin, really great skin. And she did not limit her exposure to the sun and weather. She was out there in the garden all the time. And I'm sure she wasn't wearing sunscreen. It wasn't a thing when she grew up. So I think genetically she ended up with good skin. So I'm like, okay, thanks, Grandma. Um, I'm taking that to the bank. So some of the changes might be based on exposure to sun and weather, though. So if you had a profession where you were more exposed to the sun, or if you lived in an area where you're more exposed to the sun, in Washington, might not be a problem. But you're going to get you're potentially more skin changes superficially. Skin and mucous membranes become thinner and more easily damaged as we age. The dermis, in particular, becomes thinner, and the subcutaneous tissue is diminished, as well as the number of specialized structures. They decline. So, fewer sweat glands, fewer sensory receptors, fewer, our hair follicles become fewer as we get older in certain areas. Um, and your sebum glands, your oil glands, so your skin might get drier. So with the diminishing subcutaneous tissue in the dermis, that's where you get the wrinkles, the older looking skin and the deeper wrinkles. And again, it's going to vary from person to person. So sometimes I look at people my own age and I can't believe we're the same age. And it's just, thanks, Grandma. You're going to get, because that reduced sebum, the skin will be more dry. It may appear more wrinkled because elastic fibers are reduced, and the collagen, your good old collagen, is less flexible. So your skin changes. It becomes less springy. You need that elastin and collagen for your skin to be springy. You also might develop lesions like skin tags, keratoses, um, lentiginges, which are they used to be called liver spots. So they're like the darkened spots that people have frequently on the back of their hands or arms. They used to be called liver spots. They aren't anymore. Your hair becomes gray. Imagine that. And again, that's going to vary from person to person. So it's partially genetic, it's partially environmental, lots of things that contribute to that. But overall, as you age, melanocytes are reduced in number, and that's what's giving you your hair color. So the hair also thins. You get decreased number of hair follicles. So I love this picture because it's like the same guy, half face, younger and older, and you can see some of the aging changes. And it's just interesting. And I should take a picture of myself now and then take a picture of myself in 30 years and see, do the half face thingy. I think that would be fun. I should take a picture of myself from 30 years ago and do it. See what the difference is. So another system that changes, all of your body systems change with aging, but cardiovascular changes are pretty significant because it's a pretty important system in your body. So the size and number of cardiac muscle fibers decrease. Uh-oh, makes your heart less efficient. Fatty tissue and collagen fibers accumulate amongst the cardiac muscle fibers. And so you're not getting as good a muscle contraction. You get reduced strength of cardiac muscle contraction. The heart valves thicken and become less flexible. So you might get some valvular insufficiency, which again decreases your cardiac efficiency. Vascular changes may cause a decrease in oxygen supply to the heart. Uh-oh, that's not good. And the cardiac reserve is diminished. So overall, you're just not at your heart is not as efficient when you're older. Even if you've been exercising and everything your whole life, this happens. It just happens. The arteries change as well. So you might have more arteriosclerosis, which is a loss of elasticity and the accumulation of collagen in the walls of the arteries and thickening of those arteriolar walls, which causes increased peripheral resistance. So now we've got a less efficient heart working against more afterload, and that could lead to tissue ischemia. We're not getting sufficient oxygen to our tissues. And this can be the cause of non-specific brain changes. So specific brain changes are things that specifically cause dementia and other problems, like the breakdown of tau proteins in your brain and the forming of tangles and things like that that happen in Alzheimer's. But this arteriosclerosis and changes in the arteries cause non-specific brain changes. So now brain's not working so well, or not as well as it did when it was younger. You could still be super sharp when you're old. And I've met so many older people who are super sharp, and I love that. But there are changes. So atherosclerosis can be caused by hyperlipidemia, lots of lipids in your blood. Uh, Hyperlipidemia promotes accumulation of cholesterols on the walls of large arteries, and it causes increased peripheral resistance. So again, weaker heart working against more resistance leads to tissue ischemia. And hyperlipidemia and atherosclerosis are common causes of angina, which is chest pain, myocardial infarction, which is a heart attack, peripheral vascular disease, and strokes. And so we'll talk extensively next quarter about cardiovascular disorders, and then we'll talk about neurological disorders in the next 2 quarters after that. So lots of repercussions from atherosclerosis. Osteoporosis, loss of calcium and bone mass. There is a higher incidence in postmenopausal women, but there's also a high incidence of osteoporosis in older men. So it's not limited to women. It's more common in women, but it's not limited to women. From the American Bone Society, which is it's like the American Cancer Society. It's an education organization that works on educating people about bone loss and osteoporosis. They say that two in four women, so 50% of women, will have an osteoporotic fracture in their lifetime, and 25% of men. So it's not just women. The fractures of the spine, pelvis, and limbs are common, with women having spinal compression fractures, having pelvic fractures, hip fractures. Those are kind of the most common. Sometimes wrist fractures if falls are an issue. With men, it tends to be spinal compression fractures and hip fractures. Those are the most common osteoporotic fractures in men. Lots of risk factors, some of them controllable, some of them not controllable, a lot of them not controllable. So if your genetics, your ancestry, if you're Asian or of Northern European ancestry, so that's a lot of us, you have a higher risk for osteoporosis. If you have a low body mass index, so if you're tiny, you're not putting a lot of stress on your bones. And so tiny people have a higher chance for osteoporosis. Decreased estrogen levels, can't control that. Sedentary or inactive lifestyle, we can control that. Decreased intake of calcium and vitamin C and D. We can have a hand in that. Decreased intestinal calcium absorption, that's a little harder to control. So some controllable, some uncontrollable risk factors. We can reduce the risk with adequate calcium and vitamin D intake. Weight-bearing exercises. What's the best weight-bearing exercise? How about walking? Unless if you're 100 pounds or less, if you weigh 105 or something, you might need to wear a weighted vest or something to put enough stress on your bones. But for the rest of us, walking is a great weight-bearing exercise. Um, Bone density testing as a risk reduction for women at age 50 years or earlier, normally they don't start testing you until you're over 60. So they'll do a DEXA scan, which is what this image is of it, results from a DEXA scan. It's an imaging scan where they look at your bone density throughout. And you end up with scores that compare your bone density to people without osteoporosis in your age group. And then they also compare your bone density to people without osteoporosis that are younger than you. And you get two different scores related on that. And how many standard deviations from the mean you are determines whether or not you get a diagnosis of osteopenia, which is decreased bone mass, or osteoporosis, which is even more decreased bone mass. So there you go, the old DEXA scan. Osteoarthritis, on the other hand, is not degeneration of the bone, but it's degeneration of the cartilage in the joints. And a large part of our patient population are there for osteoarthritis. Osteoarthritis may be associated with trauma or sports injuries, like when you're a cheerleader in high school, um, doing a round off into the splits. Like, I don't know if they do much harder things now than we ever used to do in the olden days, but that's a good way. That's trauma. Sports injuries, all the good sports that you've done all your life and all the injuries that you sustained could eventually lead to arthritis. So the articular cartilage thins, usually in larger weight-bearing joints like the hips and the knees. It causes pain and stiffness. There are chemical changes in osteoarthritis too that further erode the cartilage. And a joint replacement may be necessary. Bear in mind, of course, that joint replacement is an elective surgery. So a lot of osteopathic, a lot of orthopedic doctors will tell you that you have to have a knee replacement, but you don't. It's elective. I sort of, and this is only purely my opinion, I wish that doctors would take a little bit more conservative approach, send people to PT for get them on a regular exercise program, get them moving before they went straight to surgery. But I'm not in charge of the universe, as we all know. So hip and knee replacement is the most common elective surgery in the United States. And you will see hip and knee replacement patients no matter what setting you work in PT. So bear in mind, I love working with hip and knee replacement patients. It's great. And they're motivated and they want to get better and they're getting better. That's the awesome thing. But I fall on the side of more conservative. I want to go with conservative treatment before we get out the saws and start replacing stuff. Herniated intervertebral disc is common as we age. So the fibrocartilage in the intervertebral disc, if you recall from kinesiology, the disc is the nucleus pulposus, the liquid center, with rings of fibrocartilage, the annulus fibrosus around it. Well, that fibrocartilage disc degenerates with age. Darn it, right? You can lose height because your discs are getting crushed by gravity. So because the fibrocartilage degenerates, sudden stress on the back might result in a herniated disc. It causes pressure on the spinal nerves and results in severe back pain. So you can get disc degeneration, thinning discs, actually herniated disc, bulging disc where it's not quite herniated yet, degenerative disc where it's just breaking down. Normal disc, that's what we start with. If you if you did imaging on a large number of people over 30, almost all of us have some disc degeneration. because we live in gravity. Gravity is good and it builds our bones, but it's bad because it deteriorates structure. That's our wear and tear theory right there. Other musculoskeletal changes that your body goes under, skeletal muscle mass declines with aging. There have been studies done that show that you can continue to build muscle indefinitely. And they studied down with people in their 90s that could still build muscle. So what do you have to do? Resistance training. Lift things or stretch things or bend things. Resistance training. Some musculoskeletal changes are going to depend on your level of fitness. Your spinal curves will increase because gravity again over time as you age. So if you had like a tiny little mild scoliosis when you were younger, it might become more pronounced as you get older. Our normal lordosis and kyphosis increases as we age too. And this graphic, I kind of like it because I've worked with older people that look like any one of those three. So some older people have great posture and good spinal curves and whatever, and some don't. Some of it's dependent on your level of fitness, some of it's dependent on your genetics. The strength of your muscle contractions are going to decrease as you get older, and your grip is going to decrease as you get older. You can continue to work on it, but it does decrease. Your flexibility is reduced. You are stiffer. The stiffness becomes more evident the older you get. And coordination and balance are reduced. Some of that is because of musculoskeletal changes. Some of that is because of neurological changes. So we'll talk about those in a minute. Respiratory system. No system is exempt from this. So in the respiratory system, ventilation is limited by decreased elasticity in lung tissue. The costal cartilage calcifies and reduces rib movement. So when you're breathing, if you recall from kinesiology, the mechanics of ventilation, the rib cage has to expand a little bit, the sternum expands a little bit, and accessory muscles get in there too. So those intercostal muscles weaken and other skeletal muscles, other accessory muscles for breathing weaken. The costal cartilage calcifies, reducing rib movement. So it's just harder to breathe when you get older. Expiration is reduced. The residual volume is increased. So you have more air left in your lungs with each exhale. And we'll talk about the volumes and capacities of lungs next quarter when we talk about the respiratory system. You get decreased expansion for deep breathing and coughing. So you have to cough to get gunk out of your lungs. We want to be able to inhale and exhale effectively. You get vascular changes, you get decreased perfusion of oxygenated blood, and you get reduced gas exchange in the alveoli. So it's pretty hard to avoid those changes. You do have changes. So there you go, respiratory changes. Take some deep breaths. Let's go on to the next slide. Neurological changes, you get natural reduction in the total number of neurons with aging. Some of it is because of lipid accumulations in neurons. You get some loss of myelin, and so nerve conduction is going to slow down. Decreased response to neurotransmitters, just like we had decreased tissue response to hormones, we also decrease neural response to neurotransmitters, so we have a slower response time. And that has things that go all the way down the line. Slower muscle contractions, slower balance reactions, slower reflexes. So lots of different, and this is in healthy people. People with degenerative diseases, it's worse. Okay, this is healthy people. Changes in vision. Oh gosh, lens becomes less flexible, so you get reduced accommodation. Lens tends to become yellow and less transparent, and that's called cataracts. And so a lot of people get cataract surgery. Cataract surgery has been around forever. Everybody I know who's had it is super pleased and happy that they had it. Some people say it's like you cleaned your glasses. It was blurry, now it's clear, which is really nice. Normal changes in vision with aging, night vision is reduced and color vision may be reduced. Vascular degeneration may affect the retina. There are some retinal degeneration diseases and like macular degeneration that can cause some forms of blindness. So that's not good. Um, again, this is going to vary from person to person. Lots of other changes in, so vision is one of our major senses. Also, hearing loss, usually caused by degenerative changes in the inner ear. One of my colleagues who has worked with geriatric people his whole career, he said, I've met so many people in their late 90s who are super sharp mentally. There's not a darn one of them can hear. They're all super sharp mentally. So hearing loss is common as people get older. And because it's gradual, sometimes people don't notice until it becomes one of the things I noticed during the COVID pandemic when everybody was wearing masks, people who didn't know that they had hearing loss because they were reading people's lips and looking at people's expressions, all of a sudden knew that they had hearing loss because all of a sudden with the mask, they couldn't hear people. They couldn't understand them. So your sense of taste may be less, and that can contribute to anorexia or decreased appetite. Decreased sense of smell may also become a safety issue, like you can't smell the gas leak or something. The ability to discriminate among odors is reduced. So, like, oh, that's toast, that's a fire, that's marshmallows. I don't know. I guess I went s'mores there. I went to camping right away. Um, so that ability to discriminate odors, that can be a safety issue too. Diminished taste and smell sensation may impair appetite and nutrition, and then that contributes to other problems. So a lot of these problems are interlocking. Gastrointestinal changes, again, interlocking problems. So gastrointestinal changes in nutrition. Maintenance of good nutrition may be a problem when you get to advanced age. Lack of appetite because of decreased sense of smell and taste. An older individual who's living on a fixed income might lack money for adequate nutrition, or maybe it's the choice between like buy my heart medication versus buying food. And that is sad. Um, I would like to have that not be a thing, but it is a thing. Muscle weakness and fatigue, it can be super challenging just to prepare meals, and so you're not getting adequate nutrition. So my mom used to play cards at the senior center, and once a month they'd have like a meal, and one of them would either order it or prepare it and bring it, that sort of thing. And she, even though she wasn't cooking much at home, she volunteered to do the meals for their monthly thing. And she cooked something that she used to be one of those people who did big meals and invited a million people over and all that. She went, and this was in her 80s. She volunteered to make the meals, and she was so exhausted after making this big meal for all these people that she couldn't even enjoy playing cards. So that muscle weakness and fatigue can be a big player in nutrition and whether you're getting adequate nutrition. If you don't have the energy or the strength to make your own meals. Obesity in older individuals is even more dangerous than obesity in younger individuals. So it can increase cardiac workload. It can contribute to atherosclerosis and hypertension. It can contribute to type 2 diabetes. A lot of older people have developed type 2 diabetes, not necessarily because they're obese, but because they have reduced insulin, or they have increased insulin resistance because they have reduced insulin receptors in their cells, like we said earlier. Atrophy of the mucosa and glands reduce digestive secretions, and they impair absorption of vitamins, particularly vitamin B12, calcium, and iron. Those are all important. Constipation is common in older adults, and it frequently leads to hemorrhoids. It can also lead to spinal compression fractures. Constipation and osteoporosis, bad news. So, from bearing down, basically, you can put enough compression to have spinal compression fractures. So nutritional and gastrointestinal changes can have far-reaching implications for other systems as well. Urinary system changes. It goes on. Kidney function is reduced. You lose nephrons. Luckily, we have millions of them, but if you lose enough of them, you have diminished ability to adapt to changes in electrolyte and acid levels. Remember chapter 2? The kidneys were big, big players in acid-base balance and electrolyte balance. So if your kidneys have that diminished ability to adapt, that's a problem. And you also have reduced capacity to excrete drugs. Remember from the pharmacy chapter that a lot of drugs are metabolized in the liver and excreted by the kidneys. And so if you have reduced kidney function, you could get drugs could get up to toxic levels more easily because they're not being excreted as efficiently. Weakened urinary sphincter and bladder can cause nocturia, which is frequent urination at night, and incontinence, which is involuntary voiding of urine anytime, day or night. And that is very common in older people. So urinary system changes can have a big effect. Okay, remember that incontinence when we get to the next section. Other factors, infections. You get an infection, you have delayed healing because you have a reduced rate of mitosis. You have a less rapid immune response. Your immune system might also start to lose the ability to distinguish self from non-self. And stuff might get by the immune system. The immune system's like, I don't know, you know. So something might get by. You get higher cumulative exposure over your whole lifetime to carcinogens, and you might develop cancer. Your natural killer cells and your neutrophils who are going around looking for weird stuff in the body might miss cancers because they're not as efficient and there are not as many of them. And then the autoimmune disorders from the diminished ability to distinguish self from non-self. Multiple disorders are common in the older population. Integrated treatment for all interacting problems is necessary. So I hope you picked up when I was talking about all these different systems, how interacting they all are. No system exists by itself. And so integrated treatment is super important. There are people, there are doctors and nurse practitioners and other healthcare providers that specialize in geriatrics because they know this. You might get synergistic effects from the drugs that you have to take for these multiple problems. Changes in one system often cause a cascade of other problems. So multiple disorders can be a real factor in multiple medications. So a large number of medications is really common with older people, not just prescription medications, but also herbal and over-the-counter medications. They all play into each other. There's increased risk of undesirable drug interactions with the more medications you take. So I worked with one PT who was telling me his grandmother was 103. And I'm like, yay. And she still lived independently, which I thought was impressive. And she was only on one medication. And I'm like, I wonder how related those factors are, but I thought that was pretty awesome. So good genes, good health, independence, it's all good. Compliance might be a problem because when you have a zillion medications to take, it's hard to keep track of them all. You might have one that you have to take in the morning, in the evening. You might say, oh, I accidentally took my evening pills in the morning. That's probably not good. Compliance might be a problem because you have to decide whether you're going to pay for your expensive prescription or food. So, that's an issue. It's often necessary to adjust dosage and drug combinations because of unpredictable absorption and distribution and elimination of drugs. A lot of times, if elderly people are on certain medications, they will take them off every now and then just to make sure it's not causing problems or switch them to another drug. That can result in decreased toleration of symptoms that those drugs were addressing. So lots of issues with multiple medications. Like the guy in the cartoon, they combine all your medications into one giant convenient dose. That's not going to work, is it? I don't know. I do bad when I have to take two things. Like, what? Allergy med? No. Anyway,